Thank you, everybody. We're ready for our third talk, and that is Why Do Diets Fail? The Psychology of Eating and Weight Management by Dr. Kiera Buchanan. And so a little bit about Kiera is a clinical and health psychologist who specializes in weight management, eating behavior and body image. So, Kiera, you did your research with Jeannie Sheffield at University of Queensland. I know Jeannie well. And that your doctoral research explored the social and psychological factors implicated in diet failure, inverted commas. Previous to this, Kiera's research focused on eating behavior and body image. Kiera has acquired an expertise in helping clients achieve long-term solutions to their weight and eating issues through application of her research, as well as her extensive experience working in a number of private and public multidisciplinary health settings, including the Royal Brisbane and Women's Hospital and the Wesley LifeShape Clinic. Having now established her own practice, Kiera works closely with health practitioners from an array of disciplines to ensure clients' needs are addressed in a holistic way. Kiera is a strong advocate for the non-dieting approach to weight management and the early intervention approach to disordered eating and body dissatisfaction.
Thank you.
Thank you, Kiera.
Thank you. It's actually the first time I've heard that. I think Jeannie actually wrote that one. So good afternoon, everybody. Thank you. I feel honoured that you're all still awake after what's probably been a very long day for you all. So I'll try to be as non-boring or as interesting as possible. As the chair introduced me, I'm Kiera Buchanan. I'm a clinical and health psychologist, and the field that I'm particularly interested and really passionate about is that of eating behaviour and weight management. And so today what I'm going to be doing is presenting a very condensed, summarised version of some of the results of a study that I conducted with Jeannie Sheffield at the University of Queensland. And the research focused on the socio-cultural, cognitive, behavioural, emotional factors implicated in diet failure. Okay, so a lot of you here have probably already heard a lot of figures and statistics today about the prevalence of eating disorders and obesity. But just to sort of orientate you to the topic and just talk about some of the figures and statistics with relation to diet failure. So what we know is that at any one time, 1 in 4 women and 1 in 10 men are on a diet to lose weight. In fact, in Australia, in 2011 to 2012 period, 2.3 million Australian adults reported being on a diet to lose weight. Next year, consumers are forecasted to spend over $1 billion in the diet industry in efforts to lose weight. However, we also know that diets are largely ineffective. So 95% of people who do lose weight regain the weight within a few years, and 2/3 of them regain back more than what they've lost. Can you hear me okay? Yep, okay. So overall, this is consistent across popular diet methods, with one particular research study finding that all different approaches to dieting and weight management and weight loss were all equally ineffective and all had equally high levels of attrition. So meta-analyses have concluded that there is nothing to support dieting as an effective means of sustainable weight loss. And in fact, at 2-year follow-up, dieting was a greater predictor of weight regain than what it was of weight loss. So dieting and diet failure is recognised in the literature as a complex and multifaceted issue. However, much research generally focuses on factors in isolation and with very limited input from dieters themselves. So I was really motivated to develop a model that included a large number, obviously not all of the factors was possible, but a large number of factors that were identified not only by the literature, but by participants who participated in focus groups who were dieters themselves, but also factors that were identified by clinicians working in the fields of weight loss and weight management. Like I said, today's talk, I hope to sort of summarise it and to give more take-home messages and even some clinical interventions that can be used to improve client outcomes. So I'm going to gloss over some more of the more boring statistics, but please feel free to email me and I'm happy to forward on copies of that. So first of all, I'm just going to quickly introduce each of the factors before I present the model, which discusses how they are related to one another. So body dissatisfaction we've heard a lot about today, and it's defined as the negative subjective evaluation of one's physical body. And we commonly recognise that this is triggered by socio-cultural and media messages, but we actually don't give a lot of regard to the effect of public health campaigns. So one particular research study with 142 overweight participants found that after viewing public health campaigns, participants reported increased feelings of shame, increased feelings of stigma, increased body dissatisfaction, and as a result they actually reported feeling hopeless and further demotivated to actually take action and change. So dieting for appearance, and you're probably wondering, why else diet? Because clients commonly come and talk to us about wanting to lose weight to look better, to fit into smaller clothes because they want to weigh a special number. And literature actually talks about dieting for appearance as well. And what it sort of speculates is that dieters erroneously believe that their reductions in weight will be linked to a whole host of other improvements. So they think that reducing weight is going to lead to improved intimacy, improved romantic opportunities, more job satisfaction, so forth and so on. And so a lot of theorists in this field speculate that when dieters actually do lose weight but fail to gain all of the other qualities that they speculated would come along with weight loss, that they're actually really disappointed and they revert to their previous habits, which were rewarding, unlike the weight loss was found to be. Restraint. I could talk about this one for a whole day in itself, so I'll try my best not to. So dietary restraint is the conscious restriction of food in an effort to lose or maintain weight. Now, restraint pertains not just to the amounts of food, but also the types of food, so restricting particular types of food. And while unrestrained eaters, so non-dieters, eat according to physiological feelings, so hunger and fullness, restrained eaters eat according to self-imposed or rules that have been imposed on them as part of some sort of program. And so what we know is about restrained eaters is they actually have a greater urge to eat. So at a physiological level, they elicit more saliva in response to the sight, the food, the sound, the thought, and the smell of food. And just to quickly touch on one really hallmark study in this area, which is the Minnesota starvation experiment. And the take-home message for me in this was that restraint leads to pathological eating behaviour in even normal, healthy weight men. So typically we talk a lot about restraint and binge eating in overweight, emotional women who are on diets. But what we found in this experiment was it was a large sample of psychologically and physically well men who agreed to adhere to a starvation diet of 1,500 calories approximately. Quite ironic that was regarded as starvation. Actually what they found was that these men acquired a whole host of pathological eating behaviours and a preoccupation with food and eating that was quite similar to that's reported in the eating disorder literature. And in fact, this pathology was still evidenced long after the rehabilitation stage. So like I said, there's mountains of research linking restraint to a whole host of maladaptive food, eating and psychological outcomes. Thought suppression. So thought suppression is the purposeful effort to avoid thinking particular thoughts. So obviously in regards to food-related thought suppression, it's efforts to avoid thinking about food and eating. And what we know from the literature is that this effort to avoid thinking about particular things is actually counterproductive, which is known as the ironic process theory, in that it actually produces more of the thoughts that we're trying to avoid. So obviously this has been linked to food and weight loss, in that they've found that trying to suppress thoughts about food and eating led to an increased desire and an increased consumption of these foods. So one particular study, just to touch on briefly, divided participants into self-reported cravers and non-cravers of chocolate, and what they found was that regardless of their self-reported status, that following a suppression stage, all participants actually engaged in more eating of the chocolate. So regardless of whether they said that they liked chocolate or not, when they were told to not think about chocolate, they wanted chocolate a whole lot more than those who weren't instructed to not think about chocolate. Food cravings is probably something, well, I hope is something that everybody here has experienced. And what we know is that it is the intense desire to consume specific food, and it can occur in the absence of an actual hunger or nutritional deficit. Following a monotonous diet alone, even if you're meeting your calorie requirements, has been shown to lead to increase in food cravings. Food cravings then leads to an increased tendency to seek out and consume this food. And is thereby obviously a poor predictor of adherence and of weight loss outcomes. Dichotomous thinking. So this is the tendency to think in black or white, all or nothing, as opposed to along a continuum. And dichotomous thinking has been found to be one of the most robust predictors of abandoning interventions and also regaining the lost weight. I'm not sure how I'm going for time, which is normally pretty bad. So just quickly, one of the, again, hallmark studies of this was this milkshake experiment, where they divided participants into dieters and non-dieters, and then again into those that were given a high-calorie preload and no preload. And what they found was the people who were on a diet, who were given a milkshake and then instructed to eat ice cream afterwards, ate significantly more ice cream following the milkshake, as opposed to dieters given no milkshake. So this kind of illustrates dichotomous thinking. So for the dieters who had this rigid idea of what a diet was, they'd blown their diet when they had the milkshake, so they might as well completely blow the diet and eat as much ice cream as they could. Whereas the dieters who didn't have the milkshake, it didn't trigger this dichotomous thinking and they didn't eat as much ice cream. Conversely, for the non-dieters who were given the milkshake actually ate less ice cream because they're more in touch with physiological cues and less driven by rules. So they're able to say, oh, I'm feeling really full from that milkshake, don't really want any ice cream. So binge eating, we know, is the consumption of an unusually large amount of food in a discrete period of time while experiencing a loss of control. It's triggered by a whole host of other factors that go hand in hand in the sort of dieting phenomena. And what we know is that binges more than counteract any weight that has been lost, and it's positively correlated with BMI.
Based on what you're saying, what you're talking up for me is the 5-2 diet. 5 days you can eat whatever you like, and then 2 days you fast. Have you looked at the psychology of that diet if you have to fast for 2 non-consecutive days?
I think that's a really, really good question. I might actually come back to that at the end if that's okay, but thank you. Please remind me if I forget to address it. And finally, self-efficacy. So this is the belief that one has the ability to perform a behaviour. And the belief that you can change a behaviour has been found to mediate a whole host of health behaviours, specifically engaging in exercise programs, engaging in healthy eating practices, and not returning to previous practices prior to an intervention. Okay, so the boring bit. like I said, I'm going to gloss over this because I really want this talk to be more about some of the take-home messages. So please feel free to email me and I'm happy to forward this along. Basically, the study was quite a big 3-stage study, and I'm talking about the final stage, which was with a large sample of participants who reported having been on diets in the past to try and lose weight, and they completed a web-based survey. And now particular validated measures were chosen to measure each of the factors that I've discussed already. Some of those are there. And like I said, again, I can forward those measures on to people. We use structural equational modelling. And this isn't the entire model. Like I said, the final result was a very complicated multifactorial model. But this is a summary of that. We're going to talk about some of the significant relationships, but also some of the insignificant pathways that aren't illustrated on there. So what we can see first and foremost is that body dissatisfaction really precipitates this whole flow-on effect of maladaptive eating and dieting behaviours at both a cognitive and a behavioural level. So those participants who reported higher levels of body dissatisfaction were more likely to report going on a diet to lose weight for appearance-related reasons, and then an increased tendency or an increased motivation for appearance-related reasons was then linked to more restrictive diets. So the relationship there that you can't see would sort of be just, if I can whack this thing, just sort of in here, dieting for health. So what we found was that there was absolutely, there was no significant anyway relationship between body dissatisfaction and dieting for health-related reasons. So that is, people who were body dissatisfied didn't go on diets to improve their health, and people who went on diets to improve their health actually had lower levels of body dissatisfaction, so they actually felt better about themselves. And then dieting for health had no significant relationship with restriction. So people who did say they were dieting for health or performance-related reasons didn't endorse restriction as a means of achieving their goals. So then what we have here is that dietary restraint has two pathways to binge eating. So the more restrictive the diet, the more intense or frequent the dichotomous thinking style, which then led to binge eating, and then through thought suppression and food cravings. So to touch on the first one, the more restrictive the diet, the more black or white the thinker became. So ironically, their diet became stricter, it became more likely they would blow it, but they were also more likely to perceive that they had blown it. And then dietary restraint led to an increased tendency to try and avoid thinking about food, which led to food cravings, which makes sense. So in trying to go on a diet and avoid foods, your common tendency is to try and avoid thinking about them, but unfortunately not thinking about them leads to food cravings. And as we know, more severe and intense food cravings leads to more binge eating. That's interesting in itself, but some of the insignificant pathways, again, that are interesting to note is that, first of all, dietary restraint itself didn't have a significant relationship with food cravings. So restricting from food didn't necessarily lead to food cravings. It was through efforts to avoid thinking about food that then created the food cravings. Also, there was no direct pathway between dietary restraint and binge eating. So restricting alone didn't have a significant direct pathway to binge eating. It was completely mediated by dichotomous thinking and this other pathway I've referred to. So what this means is a dieter, it's not just restricting from eating food that then engages them in binge eating, it's when they have this catastrophic response of, oh my God, I've blown my diet, that then leads to the binge eating. The more frequent the binge, the more of an impact on self-efficacy. So this relationship was negatively correlated. So more binge eating equaled decreased self-efficacy. So they felt less capable of changing their situation as a result of their experience of binging. And that reduced self-efficacy was then linked to diet abandonment. So feeling less and less and less confident about your ability to change led to people giving up. Interestingly, there was no significant relationship again between binge eating and diet abandonment. So it wasn't after a binge that they thought, I'm not doing this. It was only when they thought, obviously I can't do this, that they went on to give up. So obviously, looking at the model, and like I indicated before, the earlier we can intervene, the more positive the outcomes. So body dissatisfaction and dieting for appearance kind of really were at the forefront of this whole flow-on effect of really maladaptive cognitions and behaviours. So there's lots of talk about changing and challenging socio-cultural messages in order to decrease body dissatisfaction, but there also needs to be a focus on the sort of messages that health campaigns are giving. So health campaigns need to be focused on promoting size and diversity, promoting health instead of weight loss, not making people feel bad about the fact that they're overweight, and reducing the fat shaming and the stigma associated with being overweight. Because what we've found is that this doesn't help people lose weight. From a clinical intervention, we need to be working with clients individually to help them decrease their body dissatisfaction and improve their feelings of self-worth. So for those of you who are familiar with ACT, from an acceptance and commitment therapy model, acceptance work, so working on accepting yourself for who you are. And already there's evidence to support this in finding that improvements in body image leads to reductions in a lot of the maladaptive factors I've discussed. And it's actually directly linked to improved weight loss outcomes and maintenance. So, like I said, with regards to the appearance-related motivations, that precipitated a whole host of negative factors. So what we need to be doing instead is focusing on improvements in health as opposed to reductions in weight. And again, there's a whole body of research that's starting to support this and starting to actually argue that weight is not actually an accurate determinant of health. So one really particular large study with a sample size of 900,000 adults, which is pretty impressive, which examined the relationship between BMI and life expectancy, actually found that a lower BMI wasn't necessarily associated with a longer life expectancy. And in fact, a BMI of 18.5 to 19.5, so for those of you that are familiar, that's the lower end of the healthy weight category, they actually lived a shorter life than the rest of the span within the healthy weight category, and a shorter life than those in the overweight category. So having a lower BMI doesn't necessarily predict a longer or healthier life.
Those studies that show that if you underfeed rats, they live longer in extrapolation.
Yep. I'll come back to some of these questions. So another longitudinal study found that men who were fit but obese had lower levels of death from cardiovascular disease than men who were lean but unfit. So again, there's lots of research emerging that's stating that weight isn't the best or most accurate predictor that we have of life expectancy or of health. So at a clinical intervention, at a public health first, messages can be sort of promoting this approach by saying that weight loss might be a nice byproduct of improvements of health, but it's not necessary. So public health interventions really need to be targeting improvements in health. At a clinical level with clients individually, we need to come up with other ways of monitoring health improvements. So behavioural, physiological, psychological improvements in health. Things we can be measuring are reductions in cholesterol, in blood pressure, increases in physical activity, reductions in binge eating and emotional eating. These are things that we can be measuring that are that indicate improvements in health without focusing on weight itself. Trials of this non-dieting approach have actually demonstrated improvements in physiology, behaviour, psychology, and emotionally. And like I alluded to with my own figure, is what I found was that trying to go about lifestyle changes for health improvements wasn't associated with the same flow-on of negative effects that was found by going on a diet to lose weight per se. So another big implication is to reduce restriction. So again, like I said, this is a topic I could talk about forever. And, central to eating disorders is a preoccupation or a fascination with body weight. So measuring, checking, weighing, as well as a preoccupation with food and eating, so counting calories. And so treatment with eating disorders is focused on softening some of these rules, reducing the rigidity and the preoccupation, and helping them find a more balanced way of eating. Now, considering that eating disorders and obesity are both regarded as weight-related disorders that are on opposite ends of the same spectrum, I mean, here we are today talking about them both simultaneously in the same room, it's quite ironic that with obesity, we sort of emphasise more preoccupation with food and eating, or increased vigilance with eating and with weighing ourselves. So instead of being prescriptive and restricting, interventions need to be focused on helping clients to develop their way of eating. So getting them back in touch with physiological cues, again, of hunger and fullness, and gradual change. So instead of giving everybody this one-size-fits-all program, collaborating with the clients in consideration of what they're doing now. So, and helping and guiding them towards gradual improvements in health. And using approach strategies. So what I mean by approach strategies is helping them identify what they can do more of, as opposed to avoidance strategies, which is telling them what they are doing wrong and what they need to do less of and what they need to eliminate. So helping clients, and actually there's again research that supports this in saying that flexible restraint, so a little bit of control over food and eating as opposed to really rigid prescriptive programs, is implicated in dieting success. Again, reducing food thought suppression and food cravings. So this can be done by discouraging food rules. All foods are okay, no foods are bad, not feeling guilty about eating particular foods. Also getting clients to not try and avoid thinking about food, which had a very negative flow-on effect. But instead, mindfulness interventions can be used here to help clients sit with cravings and with urges until they pass, knowing that they can act on them if they want to. They can eat the food, or they can sit with that craving knowing that it will pass. So I know a lot of my clients have found it particularly helpful when I've drawn up a graph sort of depicting the trajectory of urges. So letting them know that just like any other emotion, it pops up, it reaches its particular threshold. You can only crave something so much. You're not going to combust, nothing's going to happen. And then it'll plateau at that threshold before it slowly abates. Just like anger passes, boredom passes, all cravings and urges pass. But again, not feeling bad about the times where they give in to these urges and eat the food. So instead of dichotomous thinking, we need to encourage more flexible ways of thinking. So diffusing catastrophic thinking patterns, getting clients to identify that it wasn't one day of eating that led to them being obese. So it's not going to be one day of eating that makes or breaks their chances of losing weight, if that's all we're focusing on, but hopefully on getting healthier. Helping them develop more realistic expectations. I mean, clients love hearing about that Minnesota starvation experiment, like knowing that, even healthy weight men who aren't trying to lose weight, they can't stick to these really rigid diets. So it's okay if I slip up every now and again. And self-compassion, another topic I could talk about forever. But one particular study with self-compassion, what they found was 84 dieters, those of them who were primed with self-compassion actually ate less food than those who weren't primed with self-compassion before the experiment. So decreasing binge eating. Obviously, this is going to happen as a result of decreasing restraint, decreasing body dissatisfaction, decreasing cravings, so on and so forth. But the binges that do continue to occur, helping clients to not feel guilty about them, helping them, again, using mindfulness and acceptance to sit with it and then to get on, and how can they act in a way that kind of reorientates them with their values afterwards. And even letting them know, like, if you're going to binge, like, enjoy it, like, savor it, enjoy the food that you're having, and then get back on track. Just one sort of quick story about this. I have a morbidly obese client who was telling me that every night he eats a packet of chips, a packet of biscuits, a family-sized block of chocolate, and soft drink. And he eats it in secret in his bedroom every night. And he was boasting to me that he had eliminated all bad food completely from his diet for a week. And I think he was shocked when I was like, ooh, I don't know if that's a good thing. And we kind of talked about gradual changes and not being restrictive and not making foods forbidden. And I kind of said to him, you know what, you could eat one of those 4 things, let's say your block of chocolate, and still be losing a significant amount of weight, because that's a big calorie reduction. So why don't you choose one of those 4 things every night, give yourself permission to eat it, knowing that you're still taking action to improve your health and it's going to inevitably lead to weight loss. Take your chocolate out into the living room and enjoy it, like with the people that you love, and savour and eat it mindfully. And he said to me, oh, I don't think that I could eat a whole block of chocolate if I did that. It wouldn't be as tempting. And I actually think that if I was allowed to eat it and I was going to enjoy it, that I couldn't get through a whole block of chocolate. So there you go. And then last but not least, decreasing the impact on self-efficacy. So helping clients, again, like, be more compassionate, accept that slip-ups and binges are inevitable, and even conceptualizing it as part of a journey. Like, you have the rest of your life to get healthier. One burger doesn't make or break it. What can you be doing next meal, next second even? What can you be doing to reorientate yourself with your values? So just in summary, I hope that I've kind of convinced you that there's no or very little evidence to suggest that restrictive diets focused on weight loss are effective. And contrary to that, there's a lot of emerging research that improvements in health can be achieved through non-dieting measures and in the absence of weight loss. And last but not least, if nothing else sells you, taking into account the World Health Organization definition of health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, not only are weight loss diets lacking in evidence, they're actually unhealthy. So there's my references. And like I said, I've glossed over a lot of the details, so for those of you who want references or figures, please contact me and I'm happy to forward those on.
Thank you, Kiera, for that incredibly engaging talk. That was so interesting, and I suspect that there's going to be a whole lot of questions. We could perhaps start, because my question was also going to be that 5+2 diet that someone raised early on. And so I wonder if you could perhaps start with answering that first question.
Yeah, well, I mean, I myself didn't personally examine any diets, but again, it's restrictive on 2 days. It's making you feel bad if you do eat, so it's associated again with it's associated with restriction. It's associated with trying to not think about food on particular days, and then it's binge eating. Well, not binge eating, but it probably leads to binge eating on the days that you are allowed to eat. So, like I said, that's just my pure speculation. I haven't done any research on it, but I would suspect that it, like all of the other diets that have been examined, would be equally as ineffective.
Yes. On the 5-2 diet, there is some research that shows that it is effective and it doesn't necessarily lead to binge eating or overconsumption of calories on the non-fast days. But what I think is really important, and I think your talk highlighted on it, is to tap into why the person wants to lose weight. If they're wanting to lose weight to improve their appearance, then yes, all of those thoughts are going to be amplified and it probably wouldn't work for them. But once again, if they were looking to improve their health, and one of the drivers of their obesity was that they worked travelling a lot and had to eat out a lot, then it may be a good method for them because the restraint isn't being driven by appearance. But it can be a practical solution to arranging their intake so that they're not overeating. So I think that, I don't think anyone's got the answers about what works for who, but certainly that individual approach and being able to tailor it because different people will have different results with different.
Yeah, just on that briefly, a lot of my clients, in sort of orientating them to this way, like I say to them, if I somehow had a magic wand and I could eliminate all of the non-hungry eating that you do. So if there was a way that I could get rid of all the binge eating, all of the overeating, all the emotional eating, but didn't touch what you do otherwise, like your eating behaviours and your exercise, would you lose weight? And they're like, well, absolutely. I was like, okay, well, let's focus on that. Do your whatever you eat, however you eat. And I'm not for a second saying that there aren't improvements that can be made from people's eating, but focusing on how do we reduce binge eating? How do we reduce emotional eating? And that is through softening restrictions, softening food rules, softening guilt and the emotion associated with food.
The gentleman at the back.
The central question in your talk is why don't diets work? And I'm just wondering, given a bank of understanding of the physiological processes, there may be an alternative that doesn't necessarily involve any of the social factors that you talk about, or at least they may pale into significance compared to the enormously powerful drivers that happen when we start to lose weight. For example, there's a compensatory reduction in energy expenditure, which alone will prevent you from maintaining that weight. There's an increase, an increase in appetite that's driven biologically and genetically. And there are also triggering of reward pathways that make you want to crave those foods that you shouldn't have. All of these are massive and compelling reasons why we can't maintain that weight loss. And I'm not sure, compared to dichotomous thinking, where that balance is.
Yeah, so I think you're right. Like, we don't know exactly why diets fail, but the results, like the figures and the statistics, are compelling enough to say we don't know enough about it, and that we don't have a means of helping people lose significant amounts of weight and to sustain it. But what we do know is that we can improve health, and we can improve health in the absence of focusing on weight loss, and we can improve health through non-dieting approach methods. So getting people can eat less meals away from home, people can exercise more, people can consume less alcohol. Not necessarily, they might not lose weight, but we know that that leads to improvements in health.
Yes.
Thanks, Kiera. That was a great talk. I'm a midlife dietitian. I've just been to 2 lectures on food addiction and half a workshop, and the reason I went to these lectures is because I'm totally sceptical about food addiction. And it seems to me, as you're going through your talk, you were talking about cravings and how abstinence creates cravings, and then cravings leads to binging. And to me, that smacks of food addiction. And I wonder, how do you feel about food addiction and craving?
Well, even when I was introducing cravings, I was like, well, this is going to be contentious, because some people will say it's physiological, some people will say it's cognitive, some people will say it's emotional. But I think regardless, again, what we know is that is it helpful? We don't know enough about these things, but if clients conceptualize themselves as having food addictions, they've kind of written a story that's quite hard for them to change. So just one other example, I have a client who with binge eating disorder, and And what we talked about doing is completely counterintuitive, but instead, so she would, have negative affect, binge eat, which would then lead to more negative affect and more binge eating. So we tried just circumventing with the beating herself up and not criticising herself. So acknowledging that this is a pattern of behaviour that's persisted for a long time, to not make herself feel bad about a binge, that she can binge and still work on improving her health, and that it's not the be-all and end-all. So being self-compassionate, accepting the binge, even being mindful during the binge. If you're going to pig out, you might as well enjoy it. And she said simply that intervention alone has helped her. She doesn't freak out. She doesn't have an anxiety about, am I going to binge, am I going to binge, am I going to binge, which then increases the likelihood of her binging. She's like, I feel like binging. Yeah, it's past, and kind of gets on with the day. So I think rather than pathologizing people further, just helping them know that a lot of these things are counterintuitive and they're things that we all experience, but equipping them with strategies to manage the intensity and severity of them. I hope that kind of answered your question.
The gentleman in the back.
Those presentations. Because I think that's what we need to identify, that if we did have a condition that we call food addiction, if the current state is we're going to tell people they need to go on diets, they need to exercise more, we're ignoring the underlying issues, then that's where we're going to have a problem. But I totally agree with what you're saying. If we're able to give them some sort of intervention that deals with what's underlying the weight gain, because that's where we're going to make some progress.
Yep, thank you.
I was curious, how did you prime people for self-compassion? How you said, when people prime self-compassion, they ate less. How do you prime them?
So that wasn't my research study, but what they did was they were going to go into a food tasting experiment. They were all dieters, so they knew that would lead to perceptions of violations, which would lead to overeating. So what they said to half of their condition was, it's okay, it's perfectly normal. Lots of people really pig out during this. It's free food, it's enjoyable, don't feel bad, you're just human. Try not to beat yourself up about it. It's just one day out of your diet, all of that sort of stuff. And what they found was those people who were told that before going into the eating condition actually ate less.
Probably got time for one more question.
Is that me?
Yes.
Hi, I work as a dietitian, and I've read the If Not Dieting Then What book and started to try and bring that into my practice. But one thing I find really hard is what do I use as measures other than weight? The client especially, they're the one that wants to get weight. They want to know that's how they're going by that success, and I try to lead them, or maybe it's not a focus on the weight. It's always about the weight. They want to know, I'll get on the scale, I'm happy to, and then I don't really know how to measure other factors, like what do I look at? Blood pressure and that, it's a bit longer term from the doctor, they want to do the test.
Yeah, well, very much using, so I very much work from an acceptance and commitment therapy, so an ACT framework, and I kind of get clients to identify, what are they hoping will be different by losing weight? So how will their life be different? How will they be happier? What will they be doing differently otherwise? Because they tend to think that the weight is a barrier, and that somehow losing the weight is going to help them have this life that they've envisioned. So getting them to paint a picture of what that life is, and then talking to them about, what's ways that you can start to create that life, and maybe the weight loss will eventuate along the way. Maybe it won't, but either way, you've started living the life that you're telling me that's so important for you to live. So I guess just continually orientating them and coming up with goals that are specific to the client. So, what's you telling me that you value being more active so that you can participate with your kids? What do you think is a goal that we can focus on with regards to that? So is it spending 5 minutes running around in the backyard with the kids every day? Let's make that your goal. So goals that are specific to them and their values. And obviously if someone's going to be doing 10 minutes of incidental exercise with the kids every day, the flow-on effect is going to be improvements in health and maybe weight loss. But trying to get them to always focus on weight loss and getting on the scales, we know isn't helpful.
Please join me in thanking Kiera for a great talk. Thank you to all of the speakers and to a fabulous audience and your questions.